Okay, so I am going to round out this session. This is sort of a disparate session, not because this topic is necessarily related to unusual cancer diagnoses, but it is a treatment strategy that a lot of medical practitioners would not be familiar with. But my goal from a programmatic development standpoint is that I have to recognize that there are going to be treatments that are available, widely available elsewhere, and part of my role is to try to make sure that those types of therapies are available within the Gulf South and Louisiana in particular. So hepatic arterial infusion pump therapy is not new. It's been around for probably several decades. It was extraordinarily popular when the treatments for metastatic colorectal cancer weren't so great. And then those treatments got a lot better. So then we weren't doing as many pumps. And then it's now making a resurgence. And it's something that is not institution specific. We have a program within the LCMC health system. It is available within the Franciscan health system, and it is available within the Ochsner health system, but in trying to educate the communities out there that may see some of these patients, I think it's important to at least know that it's available, maybe get a second opinion about the value of it in any particular patient population. So this should not take, now if I could figure out how to go for, oh here, never mind, I got it. So I don't have any disclosures. So my objective is just clarify for people that are not familiar with it is what is a hepatic arterial infusion pump and why is it important? Okay, it's not a new treatment, but it's coming back into clinical practice and there's a lot more data to support it in certain patients. Briefly cover the data because it's not really so much a go through all of the studies type of thing, but that to just show you that there is data there. And then to find a type of patients that are most relevant, and they are going to be the metastatic colorectals, the intrahepatic cholangios, and then metastatic rare cancers where we're allowed to use it off-label. So what is it? So it looks like a big Metaport. So it is a reservoir, so that big old hockey thing, it has a reservoir in it, very similar to a Metaport, and then it's got a catheter, and instead of that catheter going into a vein, that catheter is being put into one of the branches of arteries off of the hepatic artery. Okay, and you sew it into place, and you put the pump in a subcutaneous pocket down in the abdominal fat pad. And just like a Metaport, we access that little silicone top thing and we put chemotherapy directly into the reservoir. And then somehow, beyond truly my capacity to explain it clearly, the pump then uses the body temperature of a patient to slowly drip the chemotherapy in over an approximately 14-day period of time. And it is got a chemotherapy in there that has a high extraction rate in the liver. So for people that have liver dominant or really liver only cancers, it's a way that you can deliver high concentrations of chemotherapy into the problematic site without having a lot of the systemic toxicities associated with systemic therapy. So it exploits the arterial supply to tumors because they like the oxygen and evidently the sugar that is within the arterial system. It has limited systemic side effects and it have higher objective response rates locally. But the important thing is this is a liver-directed therapy, not an all-over body therapy. So these are just pictures to sort of show you the anatomy of it. So this is you take out the gallbladder just so you don't have local regional toxicity to the gallbladder, but that this is the hepatic artery coming in, and you see this little side branch here. It's called the gastroduodenal artery. Sorry about that. You implant it into the gastroduodenal artery here, and then the pump comes in over the subcutaneous space over here in the right lower quadrant, and then this is how we access it, very similar to a Metaport. So the principles are that liver metastases are perfused by the hepatic artery. It delivers a really good chemotherapy that has high extraction rates in the liver. And you get 400 times the type of doses that you have with IV administration into the most problematic site. And that ultimately the half-life of it all within the liver means that almost 97% of it stays where you need it to go and very little of it gets into the systemic circulation. This is just the drug. The mechanism of action, I pretty much just said it. It's highly concentrated in the liver. But now, this is an FU-based thing, and so in patients that may have had bad 5FU-related problems, yeah, I think there's probably some data that would say that those patients would probably not maybe tolerate FUDR. But for the most part, 5FU is some component of a lot of what we do for these treatments. And so there's nothing really unique about the use of that drug. It is just that FUDR is the one that has the high extraction rate in the liver. So the applications in colorectal cancer liver metastases are predominantly if you have something where you have multifocality within the liver, both lobes of the liver, or the patient maybe has comorbidities that for which then a resection would be, impossible or too risky, and that you have a life-limiting component is going to be in the liver. And in general, since colorectal cancer, so metastatic colorectal cancer is also the risk of extrahepatic disease, we are often using it in combination with systemic therapy, slightly different when we're looking at cholangio. So really, you don't need to understand anything other than for me to say I'm not lying to you. There is actually prospective data on this, but if you were to just look at this survival curve, this curve down here is going to be the ones that are unable to be resected after a hepatic arterial infusion pump. These are the people that were ultimately able to be optimally done, and there's clearly going to be a survival benefit to adding pump chemotherapy. This is just another prospective study. Once again, there is going to be a benefit. I just want to caution people that in general, a lot of studies are going to ultimately be showing you highly selected patients because this was done in a trial format, but it's predominantly just so that we know that there is some evidence out there to support it, and that our goal is to just make it available to people and make sure that within our multidisciplinary team, we are choosing people that we think are most appropriate. And the rationale for earlier application of hepatic arterial infusion pump therapy, I think, is where we may not have considered it before. So I think we've gotten so accustomed in common cancers like colorectal to just move from first-line systemic to second-line systemic to even third-line systemic before you would consider other FDA-approved devices. So not that I am advocating for us coming in and doing a hepatic arterial infusion pump as frontline therapy, but that it's at least something where I feel like when a patient is trying to understand all of the treatment options that they may have available over the course of their disease continuum, you can at least put their head around the idea that they may be amenable to a pump at some point. So these are just the type of pictures. So for those of you that are in a medical oncology clinic with GI medical oncologists, is that surgeons will look at cases, and we're just predominantly like, how can I get that all out in one or two cases? One being you get it all out at the first case, two, you get it all in a staged thing. But that in general, you just have too much disease to think that you're going to be able to chisel all of that disease out and still have a patient with a functional liver. And so this is a patient where, in all honesty, with the availability of pump chemotherapy in every single one of our major health systems within the state, I think that where we are missing the connection is going to be when the pump program person, which is not necessarily going to be the person in everybody's clinic, is the pump person is functioning a little bit outside of the general patients that we're seeing in clinic. And so it's not coming into the discussion until much later. And you got to remember is that all of that systemic therapy is going to be liver toxic. And so if you're talking about then the risks associated with this, if someone's gotten 3 lines of metastatic colorectal cancer, this is just not going to be the Hail Mary pass type of treatment. Much better to consider it sometime earlier. I'm not saying consider it like at day 1, but at least earlier in the course. So more importantly, I think, is cholangio. Cholangio is within the unusual cancer diagnoses. It is within the problematic things we have in our state based on what Ed Trapito told us. We have significantly higher amounts of intrahepatic cholangio within the Louisiana. Most likely that is going to be related to some of the environmental exposures. So intrahepatic cholangio is something that is rare, and therefore it is seen in a bunch of different environments. So you have intrahepatic cholangio being seen in community-based oncology practices that may or may not be familiar with pump chemotherapy. It may be seen in academic practices that don't actually connect with the pump program, but that the reason why hepatic arterial infusion pump therapy is getting so much attention now is because it is likely better than almost anything we've thrown at this disease for the last 20 years. So if someone comes in and they have a diagnosis of intrahepatic cholangio and they cannot be resected, then we should be putting a pump in at the initial thing. And I just think that's really, really important for people to know, because the systemic agents are associated with a far less than 50-50 chance of getting an objective response. So there are a lot of unique issues with intrahepatic cholangio in the fact that it is a primary tumor of the liver, so it's not metastatic from another site that then you worry about other systemic, extrahepatic disease. It is predominantly a liver-related problem, and when it comes back, it is still a liver-related problem. So it makes a lot of sense to take a liver-first approach to it, or a liver-dominant approach with something like a pump. So these are just the data that supports or this is the data that is going to be the historic data on all of the ways that we aren't doing a great job in intrahepatic cholangio, and that they overall do poorly with systemic therapy or immune therapy alone. There is ample evidence to support some of the systemic therapies that we do. The issue is that we haven't really made a lot of progress. It still is one where the response rates are less than 50-50, and therefore progression of disease and your inability to then treat them effectively is going to be in greater than 50% of the patient population. We do have liver-directed therapies that have been utilized for this. So if you are interventional, if you work with interventional groups, or you're a PA that includes intervention, it's not as if we haven't shot yttrium-90 particles into cholangiocarcinoma. It's just that none of those techniques are going to be as powerful as using a pump in these patients. So this was presented at one of the major ASCO GI conferences, and I think it got a lot of buzz. And I think that is why we are all very much committed to bringing this type of therapy more broadly to hospitals within the health system. Sorry, that's like, okay, so dramatic improvement in overall survival, depending on whether or not the person was resectable or unresectable in intrahepatic cholangio. And so if you were to just look at these numbers, 25 months is a heck of a lot, better than the historical data, which was, less than that. And so you've got 84%, 90%. I mean, those are great numbers, and something that I just told you is like less than 50-50. So I just think it's really important for us to recognize that the data is strong and that we should probably be using it at most patients with intrahepatic cholangio. So a median overall survival of 25 months is significantly better than a less than a year survival prior to the introduction of this therapy. So this is just going to be yet another thing. Just look at this curve. If this is the curve where you aren't using it, and this is the curve where you are using it, you just have a significant widening of the curve, which is what we're looking at in Kaplan-Meier curves. So you've got a median overall survival of 22 months compared to 12 months, 80% of people living 1 year versus less than 50% of people. And then this 80%, 46 and then 33, it's just that you will have a little bit of drop off, but that all it means is that a good chunk of the people that are alive at 1 year will actually live to 2 and 3 years. And then obviously a 3-year overall survival in cholangio of 33% is almost unheard of prior to this therapy. So these are just the type of cases that we are talking about. So now I don't want people to only think of this therapy in someone that is unresectable. Someone can be can be resectable, but that the risk associated with that resection for whatever reason is almost a trade-off of one problem for another problem. So as Danielle was saying, is that we're not only trying to have people live, we're trying to have them live and enjoy the life that they have. So there will be times where we will have a resectable person, but the operation, so this operation would be a big operation in someone, because it would be taking out the entire right half of their liver, meaning that if they have any non-alcoholic fatty liver disease, they have any other comorbidities for which they would not be able to recover from surgery. If people have a BMI over a certain amount and their basal metabolic rate is just much more strenuous on their liver, they are not going to tolerate some of the things that we want to do in the liver. And then you'd say, oh, and some of them just say, you got to be dreaming if you think that you're going to operate on me. So having an alternative that still has a very high objective response rate is not just about resectable or unresectable, it's about what's appropriate for any given patient. So this slide is really just showing you that this when we see this little multifocal cluster of grape things, that is an independent predictor of recurrence. So if it's one big cannonball, we feel a lot better. If it's like one mothership and then a bunch of little daughter cells, we don't like that biologically. So this is before, this is after, significant objective response rates. So even if you were saying, oh, hey, someone's got a problem that would require a major liver resection, and you can then get an initial response, we call that neoadjuvant, the initial response with chemotherapy, and make them a safer liver resection, then by all means. That was one of the slides that I earlier showed where you could use it as a complementary or as something that would use prior to consideration of resection. And so these are just in case you work with people that would want the current guidelines. So this is not like we're just throwing it out there. There are guidelines out there, and that people within, I don't want to call them more sophisticated, let's just say more heavily resourced parts of our country have this readily available and would be way more integrated into patient management. Whereas I think within a state that is more rural, a lot of different types of practices, we're just having trouble getting the information out on how we should be better integrating this in, without saying, oh yeah, but you have to actually come all the way to New Orleans to get it, which a lot of people within our program have to come from a ways away. You do not have to go a ways away for this therapy. So it's really just looking up here at the top of the screen is just all the different types of people. And then you see how it says colorectal, cancer, all this, is that, oh yeah, the reason why you have all these things versus this one that goes straight to here and this one that goes straight to there is that the reason you have that is because under no uncertain circumstances are we trying to say, oh, you're going to go off the standard of care. The standard of care also for colorectal comes with like a 70% objective response rate. It's just that there will likely be patients where you would want to consider it somewhat earlier in the course of their disease, or at least get their head around it as an option for them. So in summary, it is not a new technology. It's been around for decades, but it is making a heavy resurgence. And my goal in my role as a programmatic development person in this state is that we need to raise the floor. We need patients within the state of Louisiana to get the same access and the same level of care as those that are in at the University of Alabama or at Memorial Sloan Kettering or at MD Anderson. We should not have to, especially for something that we actually have here, people should not have to cross state lines or be driving 200 miles for this therapy. So we need to raise the floor. It has to be known. We have to understand it. This group, like CAGLA, is about building those collaborative relationships between healthcare organizations. All of us on the pump side all get along really great. And therefore, we know where it's available at Our Lady of the Lake or at Oxnard Main campus. It is really just making sure that we, as a group of people trying to bring pump chemotherapy into more practice in the state of Louisiana, are all on the same page with what types of patients we are most concerned about targeting. So unresectable patients with liver-only or liver-dominant disease should absolutely be considered, and the data is that we should be using it probably earlier. So maybe you give frontline chemotherapy, and then if you still have a problem after that 12 months, instead of like poisoning them with another full set of second-line chemotherapy where you have a much lower likelihood of an additional response, we should maybe try focusing on the liver. And then you would, and when we're trying to use it where you would have someone that is borderline resectable and where resection is likely to give them a much longer survival, but you're trying to use it potentially as a bridge to something more long-term successful. And the therapy is available in several locations within Louisiana in almost every health system that I can think of, other than I'm not 100% confident it is available in Shreveport. And that is it. Okay, any questions for me? Well, the bad news is, so the pump is pretty much in forever. And so why I think it is super important to have standards for pump placement and for pump maintenance is because once you plug that into that artery, that maintenance of that pump is critical. If that pump goes down, meaning you clot that thing, it's kind of like when someone with a Metaport goes 3 months without having it flushed. So you have to put saline in that. I mean, you have to put heparinized saline in that pump between cycles. And yes, that drips in over the next 14 days between cycles. But that one of the then challenges when you are trying to put it in perhaps a not as educated patient population, or we can talk about the natural disasters that it's almost like once you put it in, it's a bit like an organ transplant. You got to make sure that that patient is covered regardless of what can ultimately happen. Do I think that it's going to be, really hairy at like 13 days and 1 hour versus 15 days, but the maintenance is important. Once it goes down, you will then lose your ability to use that therapy ever. Good question. FUDR is the drug. Now, the Entera people, so there is a booth that could probably go into to a little bit more detail on why they have chosen that, or whether or not there are other trials out there using different drugs, maybe that would be pertinent to something like a metastatic sarcoma, or maybe something where a different drug would be more appropriate. FUDR has been the choice because the liver extraction rate is so high, and FU-based therapies are very generic amongst most GI cancers. So I think it's just been a reasonable choice. But that's kind of no different than we use an adriamycin-based chemoembolization, even in tumors that adriamycin is not even part of any systemic protocol for that type of cancer, and yet it still seems to work in that setting when you're putting directly into the liver. But that's a great question too. So the answer to that is yes. So everything that is ultimately within CMS guidelines, it should be able to be covered. Similar to some of so in my world of unusual cancer diagnoses, and we use really high acuity subspecialty drugs and radioisotope therapies and things like that. So do I think that it's always a cakewalk to get it through different types of payers? And it's not really just about Medicare and Medicaid. It's just that you may have to appeal or make an argument for it. But within our program, we see people with managed Medicare and Medicaid from Arkansas, Oklahoma, Louisiana, Mississippi, things like that. And I would say that for the most part, if it is CMS, if it is an FDA-approved application for it, which I have covered both those. If I'm using it off-label, I can imagine that's going to be a higher mountain to climb. But that I think my short answer is yes. My longer answer is that sometimes it's a fight. Yeah. Yeah, so our program is probably the youngest within the region. So I can ask John Mizrahi on whether or not he's had that. So the auction program is just more, I think, more mature than ours is. Okay. we have not had those issues yet, but that I can say, but I live in a subspecialty world where I'm allowed to do almost anything under humanitarian device exemption. So I'm constantly appealing for stuff. So I think that a lot of it is documentation and you're having the infrastructure to explain your rationale for doing something and then doing it the way that you think is most appropriate for the patient. Any other questions? Okay, well, thank you so much. I know that I kind of have an eclectic. Yeah.